Welcome you all. This first session of Complex PCI 2021. Make it simple, technical forum A to Z. So I'm very happy to have a distinguished moderator and the many panels and panelists in this session, and so featuring training session and clinical workshop one, step one, plan before procedure. So I'd like to introduce Alan Young as a co-moderator and many excellent panelists. Dr. Adialtos from Indonesia, Dr. Hamazaki from Japan, Dr. Kwon from Korea, Dr. Patwari from Bangladesh, Dr. Swasat from Thailand, Dr. Chao from Taiwan. Really thank you and appreciate you all for the joining this session. Right, we're going to start first lectures. Dr. Dogu Bak from Asa Medical Centers. He will give us two low diverged in a cath lab PCI versus bypass surgery in complex PCI. Dr. Bak, please.
Okay, thank you, Dr. Park and Dr. Allen and all our friends. So today my topic is about PCI versus bypass surgery debate. Title is two road diverged in a cath lab and PCI versus bypass surgery in complex coronary artery disease. So this is my disclosure. So I'm going to start my case presentation, and this is somewhat very complex case, 64 male and presented with stable angina, and there is no diabetics, and angiographically, although nearly total obstruction, distal main and suck ostium was nearly total obstructed, but this patient was a stable angina. So, and looking at the areocranial view, we can see the diffuse disease extended to the mid-LAD part. Also, the spiral view shows the near total occlusion of the suck ostium artery. And right coronary also significant disease, and proximate RCA, there was some diffuse disease, and so 64 male, stable angina, no diabetic, and 3 vessel left main disease, and the syntax score is a high rank score 38, and this part is sometimes encountered our real world complex procedure left main 3 vessel disease. Two very different procedure for complex coronary artery disease. One is a very invasive bypass surgery. One is a less invasive PCI. So, and this patient is we decide to heart team discussion. Finally, patient want non-invasive PCI rather than invasive bypass surgery, and although the wiring was very difficult, nearly take more than 15 minutes, and we used the Sion Blue, Choice PT wire, BMW wire. Crusade was failed, and finally we used Gaia second hydrophilic. This is a really CTO wire used, and the region successfully passed, and the BMW long wire was changed. This is a take of 15 minutes to wire passage. And next, and the procedure is very straightforward. We are already planned, and the pre-dilation already performed the distal suck and the middle LAD part distal main, and the post-balloon CAD shows very diffuse coronary artery disease. Our essential the tool used, IBUS was used from the distal suck, and the main is we can found and very diffuse disease in the suck. And also we checked the mid LAD to the distal main. We also found very diffuse LAD disease. So we put the drug-eluting stent, long stent in the distal prox suck, and the mid LAD part also long stent. and high pressure balloon dilation. And then we do distal lamp main, put the balloon crush technique and the circosteum stenting lamp main balloon crush. And we do final kissing balloon dilation aggressively in both branch using high non-compliant balloon. This is a final view. In the epicranial view, we can see there is a very the improved the blood flow, and the lumen was widely open. The area coral view, we can see the nearly normal coronary artery looks like it's very complete revascularization. And the RCA, we put the direct stenting, the drug-eluting stent, and this patient is treated well. Every disease vessel, residual syntax score less than 5. There is one of a very complex patient, 64, relatively young. However, we treated well the PCI. Like this, 2 myocardial revascularization procedure. This shows very well showing the mechanism is bypass surgery and the bypass the flow limiting, even non-flow limiting region. However, stenting is a flow limiting was treated, but some part of a non-flow limiting region was remained. So this article is published in JAG a couple of weeks ago. Very nice paper showing the underlying mechanism PCI and bypass surgery. They divided 3 mechanisms. Is inducible ischemia. Resting is okay. Exercise ischemia was induced. There was a main invasive treatment mechanism is restoring coronary flow capability. There is a concept of functional ischemia, functional revascularization. Another is obstructive disease, and in case chronic ischemia, hibernating related, and acute ischemia, ACS, and there is the invasive treatment mechanism is reperfusion. And the last one is risk of impaction prevention. There is an impact prevention. So looking at the 3 different mechanisms, coronary artery disease treatment, PCI is good for inducible ischemia treatment, and also reperfusion treatment is okay. However, impact prevention is not good. Bypass surgery is everything is good, restoring reperfusion, impact prevention, also expected treatment effect, and functional ischemia symptom relief, and anatomical ischemia relief is restoring cardiac function and improved survival, and the MI prevention is the MACE prevention, also improving survival. So, and this paper shows the non-lethal MI prevention. There was a main difference, PCI versus bypass surgery. If you reduced myocardial spontaneous MI, there was a very closely associated difference in mortality, very positive association. P-value was the significant. That was done by multiple meta-analysis. Also, network meta-analysis shows that if you reduce the myocardial infarction spontaneous, there was a very strongly associated all-cause mortality. So, and a couple of weeks ago, a very nice paper that was done by Patrick Survey, and the summarized all the available study and PCI revascularization over the last 40 years. Also, counterpart, a very nice review article is done Michael Mack and Freddie Moore, his cardiac surgeon. There was summarized the myocardial revascularization surgery over the 50 years. This photo shows the SJ Park photo, done BEST trial and pre-combat trial. So, and the still controversy in PCI bypass surgery and the heterogeneity of anatomic group. Also, some data shows the conflicting result registry and RCT, and the length of follow was still controversy. What is the best endpoint, the mortality or MI, repeat revascularization, or death of QOL, day of hospitalization or quality of life? Also, concern is that there is a catch-up concern. Is complete or incomplete revascularization is also remained the unmet issue. Published evidence consistently shows the very different risk profile and the time varying benefit for PCI and bypass surgery. In real world, the majority of a patient has a particular clinical anatomy characteristic. There was a clearly driven and decision making. We require the individualization on the basis of the patient risk profile. Also, we time to get over the debating and controversy and expect the release of next version of guideline. And the Excel trial, this is some boost of debate, PCI versus bypass surgery. There was a time-dependent variation, relative treatment effect, PCI versus bypass surgery. Also, there is some all-cause mortality issue was raised. However, if you're going to summarize all available clinical trial, and if you include the left main plus multi-vessel disease, mortality was better for bypass surgery. If you confine the left main disease done European Heart Journal, mortality was there is no difference at all. Also, there was a nice paper done the Stuart Head, diabetic, non-diabetic, no difference, diabetic bypass surgery is still better, and multi-vessel disease is bypass surgery is better. Left main is absolutely no difference at all in terms of all-cause mortality. And the soft clinical endpoint, and as we expected, early part, PCI is always better. However, if you're going to do long-term follow-up, more than 1 year, 2 year, 3 year, overall quality of life similar between two groups. Also, our next future, and nowadays, a lot of state-of-art PCI make a complex PCI to be equivalent to bypass surgery using functional and imaging concept. And a lot of IVUS we know well, pre-PCI and post-PCI, a lot of FFR is very helpful to decision-making, treatment, or just leave it alone. So, and the Syntax trial shows that if you're going to do a state-of-art PCI and the Syntax bypass surgery, Syntax 2 PCI shows the equivalent long-term clinical outcome. Also, surgery part is concomitantly improved over the time, and the Lima or radial artery graft, there is graft, the harvesting techniques improved. Also, SVG graft technique also improved. There was also important part is bypass surgery. So, and the patient definitely has a different indication, clinical and rich anatomy characteristics that is quietly clearly drive the decision making. Some part favor bypass surgery, some part favor PCI. Also, we should require heart team approach. And for instance, this is an obvious choice. The left main treatment, less than 1 minute PCI procedure. Right part is this patient, we don't consider PCI at all, and this patient should be referred bypass surgery, absolutely. Some part is equipoise patient, this is a distal left main and RCA disease, and we can treat well with the PCI as well as bypass surgery. Looks like some complex disease. This patient we treat well, PCI as well as bypass surgery. So PCI, bypass surgery, two different merit, and the PCI definitely less invasiveness, early outcome is better, more rapid recovery. Bypass surgery is also has the important merit, rate advantage, more durable, and MI prevention. Also PCI, bypass surgery, available data is there is no difference, hard endpoint, also mortality. And the last slide, PCI and bypass surgery, different intervention is performed in different patients with a different aim, is performed by interventional cardiology versus the cardiac surgeon. Surgery is associated higher peri-procedural risk and the discomfort, but better long-term clinical outcome. PCI assure outcome comparable to surgery with a much lower invasiveness. Two interventions are complementary, not antagonist. Thank you for your attention.
Great. Nice talk. Okay. We're going to have some discussion time after 4 lectures. And so we're going to move to the second talk from Dr. Gu Bong Gwon from Seoul National University. He will give us, make it simple, practice with invasive physiology in complex PCI. Dr. Gu, please.
Thank you,
right.
Professor Bach, for the kind introduction and invitation. I'm BK Gu from Seoul National University Hospital, and today I'd like to talk about the invasive physiology in complex PCI. So for this title, Physiology in Complex PCI, some of you may have some skeptical or cynical thoughts while thinking that the invasive physiology is only for intermediate or simple lesion, or some may think that the physiology itself is very complicated and complex. So any of physiology-guided PCI, to me, is complex PCI. Today, I'd like to share some case examples to show how physiologic assessment can make these complex lesions or complex PCI simpler, and I'd like to start with the left main bifurcation lesion. So you're looking at the angiogram taken 14 years after cipher implantation from the left main to the LAD. There is a tight stenosis at the circumflex ostium and big diagonal branch ostium. So if you want to do something for this, you have to be ready for the complex PCI. However, if you measure some physiologic indices before you do anything, you'll see that the diagonal branch FFR 0.87, circumflex FFR 0.93, so that it's not for the complex PCI, it's for the medical treatment. And here's another example of the very obese patients after left main to LAD stent implantation. So there's some haziness and stenosis at the first diagonal branch, ramus branch, circumflex branches. It's very difficult to have an information about which lesion needs additional PCI. But if you have a pressure wire, push it, giving some adenosine or the necrandial, you'll get this information. So ramus is okay, circumflex is okay. So if you fix lesions, the diagonal branch will be a target. So it is also helpful to find the couple lesion. This is an angio of 65-year-old gentleman, stable angina. So looks the patient have some diffuse disease, and there seems to be some distal main or the LAD osteal disease. So when I advanced the pressure wire, measure FFR, it was 0.69, very low. Then what we need to do is pulling back the wire under hyperemia to find the culprit. You see there is a big step up at here and here. So this is a true distal left main and LAD osteal lesion. So as the pressure wire was there, what I did was a FFR guided provisional strategy. So this is angio taken after left main to LAD stenting. We generally know that this lesion is not functionally significant, but we also know that that's not always 100% true. So for this circumflex, FFR was 0.67. So I had to fix this lesion with the first kissing balloon inflation. As the pressure Y was there, it's not difficult to measure FFR. It was 0.83. So I think it's quite low for the circumflex RT. So this is final angio after tap stenting and final physiology, circumflex FFR 0.9 and LAD 0.95. I can say that I did the functionally complete revascularization. So about the multi-vessel, multiple lesions, here is an angio of the patient, a 52-year-old female, stable angina, seems to have 1, 2, 3, 4, 5, 6, 7, 8. So that the distal left main disease, triple vessel disease, 8 lesions. So the question is how we can fix all these lesions by multi-vessel PCI or the bypass surgery. But before we do that, let's make a physiologic assessment. So LAD 0.83, so we can forget about left main and LAD, and circumflex 0.88. So that the question is now that why the patient have symptom. So for this RCA, FFR is 0.65. So, but even this vessel is significant, we have to find the culprit for the symptom. So what we need to do is that pulling back the pressure wire under the hyperemia. So there wasn't significant pressure step up while the sensor is crossing lesion number 6 and 8. And you see that there is a big step up at the lesion number 7. So that this should be the first target. So after stent implantation, FFR has become 0.81. So by angio, the patient had a left main triple vessel disease and 8 lesions. And after physiologic assessment, the patient was now coded as a 1 vessel disease, fixed with 1 DES by FFR guidance. Another interesting technology is that to define the physiologically significant lesion or the target for PCI. So the patient have a really diffuse disease from left main to the LAD and also to a big diagonal branches. So IFR at the far distal LAD was 0.87. So the question is, send the patient to the surgery, full metal jacket with the 2 stenting for both LAD and diagonal branches. But when we do a pullback of the IFR, I can find some spots where the functionally significant lesions were aggregated. So this can be co-registered with the recent sync vision technology. You see that these lesions can be fixed with 1 stent in this figure, so that if I put a stent here to there, IFR estimate after stenting was 0.98. So we don't need a 2 stenting for the diagonal branches. So this is how the physiology can be helpful selecting the right target for the PCI. And it can also be applied to the acute coronary syndrome. So this is angio who is referred from other hospital for bypass, emergency bypass surgery because the patient's symptom was unstable, maybe due to this lesion. And the reason for the referral was due to this distal left main LAD lesion. So the question was whether we need a complex PCI, bypass surgery, or others. So I measured the FFR at this for this left main LAD lesion, and it was 0.85 despite the LAD osteo MLA 3 square millimeter. So the lesion is now physiologically 1 vessel disease, and this lesion is fixed. So you may be still uncomfortable with leaving this alone, but the follow myocardial perfusion scan shows that there's no perfusion defect here. So finally move to a little bit more complicated situation for the post-bypass surgery and congenital anomaly. So here is an angio taken 22 years after bypass surgery. You see that the distal left main LAD lesion have a very diffuse disease, but there was also some regression of the lemma to the LAD, so that the competing flow from the ostium of lemma to the LAD and rather small. So the question in this case is whether this lemma is physiologically working or is left main to LAD PCI is needed at this stage. So that to understand that, what I did was that the advanced the pressure wire and measured the resting PDP 0.92 and FFR 0.79, which means that considering this number means that this lemma, even looks regressed, is still working. So you can still do a PCI because FFR is 0.79, but I think as this one is working, it can be under medical treatment as well. So this is my final case. Would like to talk about a little bit complicated situation as anomalous RCA from left sinus of Valsalva. We are now encountering more of these cases due to the CT scan, but even the guideline is telling us that we don't know how to assess and how to fix this lesion. So here is one case of anomalous RCA. You see that the right coronary artery is from left sinus, and in the IBUS, there is a significant pinching between the aorta and pulmonary artery. So the question is whether the patient needs a PCI or surgery. So first, FFR 0.91. So it may be good, but we know that this lesion has a dynamic compression. So to induce the dynamic compression in the cath lab, I give the dobutamine atropine, so that this is angio taken at the time of dobutamine atropine, heart rate of 180, blood pressure around 200. So when FFR was measured under that stress, even under that stress, FFR was 0.87. So for this complicated congenital anomaly, PCI surgery is not needed, just medical treatment would be fine. So in the beginning, you might have rather skeptical thoughts for physiology in complex PCI, but I hope that now you agree with this conclusion that coronary physiology is an essential element for understanding the disease and clinical decision-making. Therefore, use of FFR or non-hypertrophic pressure ratio can help operators select the appropriate treatment strategy and making the complex PCI simple. Thank you very much for your kind attention.
Great. Let's stop. Alan will.
Yes, thank you very much. Pleasure to be here. And our third lecture is on hope for the best, but prepare for the worst. What should be prepared before PCI for chip and protected left main, low EF, shock, etc. This is to be given by Dr. Sanao Nakamura from the New Tokyo Hospital in Japan. Dr. Nakamura.
Okay, good afternoon, my dear friend, ladies and gentlemen. First of all, I'd like to say congratulations on Complex PCI 2021, and I'm happy to join you. Pleasure to share my idea. Unexpected accident, if it can happen, it will happen. Everything can possibly go wrong, will go wrong. This is a very famous Murphy's law. It is what it is, yes, but I really don't know what to expect this theory. I think 90% expected accidents to be avoided. US got an unnecessary event. For saving all unexpected event, you need a good eye of prediction, and you know the way of the preventing, and you need to have a weapon, and finally you need a good technique. Today, I would like to show the 3 unhappy events. Please watch and feel and think. First case is a perforation. This is a case of PCI for simple LED proximal lesion. 20 years ago, we have some trend with the direct stenting without the predilatation. In this particular case, we did the direct stenting with a 3.5 cipher, and then patient raised the voice of the screaming. We check angiogram immediately and understand the situation of the big perforation. Then within a short time, we check the epicardial view because I want to check possibility of implanting the graft stent. Actually, my junior technician prepared the graft stent within a 3-minute. This quickness is very important. Again, we have epicardial view for checking a possibility of the graft stenting to confirm the gelling of the circumflex and confirm it's okay, and then the graft stenting. Because the quick response after the big complication, finally patient could back to his ward directly, not ICU. This is the final figure, no pericardial fusion, no ECG chain, no MI. From the beginning, most of the time, if you use IVAS, we can recognize the size of the vessel, presence of negative remodeling, and the location of the clarification. So close to 100%, we can predict. So in this case, we can do prediction of preventing with the IVAS, and the technique, mostly importantly, we need a quickness. And if possible, better to have a technique of the pericardial centesis. If you have all, you and your patient will be very safe. Second case about complication during the left main PCI. This is a case of very simple left main body stenosis, looks okay around the circumflex atrium area from this angiogram, which means no need intervention of the circumflex. At first, check IVAS. IVAS showed no obvious disease in the circumflex atrium area as we expected. But IVAS showed the calcification on the ceiling of the left main, just opposite to the carina. Then my junior started the PCI. Actually, after checking IVAS, he carelessly out of the circumflex guide area, which is a protein guide area, but continued stenting in the left main, which with a sort of the no risk of the circumflex occlusion, but it happened. At that time, I was there and rushed to join him, and thanks to the technique of the CTO guideline technique, within 5 minutes, successfully crossed the circumflex, then balloon, and the cavity, that we recovered the situation. From the beginning, we had almost no region of the entrance of circumflex. Why it happened? Let's remember that we have the calcium region on the ceiling of left main. Actually, we had a paper regarding a complication during the bifurcation PCI using OCT. In this paper, we show the calcification opposite to the side branch is a strong predictor of the side branch occlusion. This is the mechanism. We have a soft flap, everything is okay, but we have a calcium plaque just in front of the carina, stent balloon, sometimes shifted the carina, sometimes making a side branch stenosis. Actually, these are my junior's paper. So in this case, we can predict and preventing. And if we have a weapon and a technique, at least we can minimize the risk. The third case, this is a CTO PCI related complication. Of course, currently we have established a technique of CTO PCI, resulting in a success rate close to 100%. So if we follow the rule of the CTO PCI as a professional way, complication never happened. This is the end of the 60 years old gentleman with several coronary risk factor, good LV and renal function, having angina due to LD CTO. Cardan epicranial view, LD actually no stent CTO, and a very charming great size collateral from the epicardia with some coaxial reached across the LD ostium. Bilateral femoral approach, back after catheter and Salvan. My junior started regular approach directly from the beginning. We succumbing to the temptation of the great size charming collateral. Actually, regular guide went through the big collateral without any struggle, then soon creeping up to the LAD close to the exit. And then luckily or unlucky, Gadway went to the space of the left main. Actually, she is young enough to continue the procedure with a careful consideration about the position of the guide wire with the externalization until the externalization. She couldn't help herself doing like this. Soon after checking IVAS, she recognized the situation. IVAS showed the guide wire went through the false lumen in CTO. This is the schema of the situation, went through the false lumen. As actually soon we could recognize the growing hematoma from the ostium, the LAD. If you continue, so actually definitely we will lose the circumflex. So change the operator to me. I started IVAS guided rewiring. With pressing IVAS gas just proximal LAD, where we can see the LAD lumen. I use another guide wire, second wire, to find out the seek the true lumen. This is actually the schema with a corrector root. Then ballooning a stenting, and this is after the wiring, and then stenting, and the IVAS, and the IVAS from the circumflex. Actually, this is a final angiogram. So we can predict rough guideline may lead this kind of complication. Okay, we can predict with a gentle guiding, with a careful watching with the IVAS. Reading IVAS and the precise guiding is very important. By the way, what is the key element for us to predict and predict? First, we want to pick quickness. This is a case of 20 years ago, just after launching the Texas Stent in Taiwan, very unforgettable case for me. 60-year-old lady with relatively heart failure patient, very low ejection fraction, 20%, very poor general status because the refusal of the cardiac surgeon team, they offer me left main CTO PCI. This is angiogram, very low ejection fraction, left main CTO. And she had the faint collateral from the RCA. I did open up the CTO with the IVP support, guidewire pass in a stent in the left main, KBT with a 30 minutes, within a 30 minutes. This is a very quick procedure. So actually, surprisingly, she recovered the left ventricular ejection fraction to 40% after 1 year. Just want to say, quickness is very important. One more, smart use of appropriate supporting device. This is a case of 6-year-old gentleman with repetitive heart failure, 48-point intact score, high Euro score, high ST score, minimal coronary risk factor with a poor control IDDM, very low ejection fraction, high level BNP showing more than 500, very poor general status, showing a more than 55% cardiomegaly with some sign of heart failure. ECG show the broad ischemia. This is RCA showing the distal CTO, and this is left system, also LAD and circumflex CTO. Currently, we have a great cardiac support device named the Impera. If you use the Impera very safely, we could finish to open up the LAD, and then circumflex, and then RCA, almost at once without patient collapse. And 1 week after PCI, we have a beautiful picture of the chest X-ray with showing a complete recovery from the heart failure, and with a dramatically reducing a BNP to 70 using appropriate supporting device is very useful. Next key element is vessel preparation. And next case is done by Antonio Colombo, actually my great friend, and he's a great operator with a great wisdom. He never failed to surprise me every time I met him. I'd like to introduce a case. This is a case of a very severely cultured proximal LAD and circumference, very staggering one. Especially we never expect good expansion in the circumference. As far check OCT, diffuse severely calcification in the circumference proximal is showing a large calcium and a thick calcification. Use shockwave 2.5 proximal to the mid circumference and post-dilatation 3.5 balloon, the very high pressure. And then stent in a 2 stent and a circumference to left main following a pot. And if you check the OCT image in a circle, we got a beautiful expanded stent slot on the best position, which is hard to expect. Next LD from distal to proximal shockwave 3.5 long region, 4 energy shot in each region. We can see the 2 parts were crack and a thick culture region and an unusual expanded region without crack. Then stent in the LAD all the way down, beautiful expand the stent slot and the best center position, which is never expected at the beginning. This is a final angiogram. No one can expect such beautiful open up the LAD and circumference, even such big rock pipe. Finally, I'm very firm believer that everything happens for a reason. For if we can remove the reason, accident is not supposed to happen. Thank you very much for your attention.
Thank you very much. So our final lecture today is going to be given by Dr. Antonio Colombo. He's going to talk about how to make the complex PCI simple. Planning is everything. Antonio?
I think it is time to make a little bit of a shift in our planning and the way we do angioplasty. And I want to start with this statement. Stent implantation, I don't believe it should be anymore the default approach when treating any coronary stenosis. We need to distinguish a malignant from a benign dissection, and angiography is not always the best tool for decision making. There is no question that when you deal with a focal lesion, like the one in the upper side of the slide, stenting becomes the default procedure. But when you have long diffuse disease, here we have an FFR of 0.68. I do not believe it is appropriate to stent with long stents, these left anterior descending. So we need to come out with a different approach. And I talked today about drug-coated balloon with FFR evaluation to limit stent length. Large vessels, 3 millimeter and over, and short stent, I took 25 millimeter as a number, but you can say 28 or 20, with optimal result evaluated with imaging are the default approach. In other situations, such as long lesion with diffuse disease, including total occlusion, I believe use the same approach and implant long stent with imaging optimization like we do today is a possibility, but I would like to introduce optimal lesion preparation with PDPA, proximal to distal pressure measurement, and then, if it's appropriate, use a drug-coated balloon. I do not believe we have to do this kind of PCI. This is not contemporary interventional cardiology. Immediate result may be perfect, but a few years after is not rare to see this total occlusion of long stents. A new approach, here you see a complex bifurcation with a long disease on the diagonal branch. We decided to take a stent in the LAD, but then to treat with balloon the diagonal branch, you see a dissection, but the pressure measurement utilizing a pressure wire to do the PCI. Let me come back. There was 0.89 and was not critical, and we just used a drug-coated balloon. Here is another example. You see a long diffuse disease of the left anterior descending calcific. This was prepared in the usual fashion, pre-dilatation with high pressure balloons. Balloon was not expanded, utilized shock wave. I go quickly here because this is nothing new. Use IVUS showing calcium, as I said, shock wave, then cutting balloon, then again high pressure dilatation, and then cutting balloon more distally. Here you see optimal lesion preparation proximally, some dissection distally. Instead of implanting a very long stents, we just implanted the stent at the bifurcation in the proximal part. And what do we do for the distal lesion? So stent implantation, 24 millimeter in the proximal part. Then in the distal part of the lesion, we optimized with further balloon dilatation. Then we see that there is a dissection. We measure the pressure gradient in the critical area, and the pressure gradient was not acceptable. Then we did further balloon inflation, and then because the pressure gradient was acceptable, we did a drug-coated balloon, 40 millimeter, with a very acceptable result. Let me show you what we did for the physiology evaluation. This was the original dissection with disease distally. This is the final result. The pressure gradient moved from 86 to 94. Distally was 84, then 91, and we did a contrast FFR that went from 77 to 87. This approach tells us that not every dissection needs to be stented. It is time to evaluate dissections and understand which is a malignant from a benign dissection. Again, the final result with a single stent and a drug-coated balloon for the distal vessel. This is another example, is an intermediate branch, a long lesion. Instead of implanting a 30 millimeter stent, we pre-dilated. There is a mild dissection. We evaluated the dissection with a pressure gradient, and we use drug-coated balloon. Another example in CTO, there is a randomized trial running to utilize a proximal stenting and DCB distally in order to avoid a full metal jacket. You see a proximal stenting implanted and the distal segment treated with drug-coated balloon. A final example, this is a very tortuous long LAD with a focal lesion in the diagonal branch. Instead of implanting long stents, we did a PCI and measure the distal gradient, the drug-coated balloon, despite the presence of a dissection. In this case, the measurement was done not with a pressure wire, but with a QFR, and the 6 months follow-up in this case shows a perfect healing of the dissection with very good sustained result. We are collecting data, and I hope by next year we will have a case series with not immediate result, but with 2 years follow-up is that what we like to present. So I'd like to conclude with this slide, an approach to limit stent length. The lesion is optimally pre-dilated with a goal to reach a good angiographic result. IVUS optimal but suggested. Following pre-dilatation, there is an occlusive or advanced dissection. You progress to stent. Optimal result with or without dissection. You measure the pressure gradient. If the pressure gradient is less than 10, you go with a drug-coated balloon. If it's a high pressure gradient, then you switch to a long stent or maybe even to a focal stent. All pressure gradients should be evaluated for at least 5 minutes to make sure that they are stable and do not degrade. Thank you very much for your attention.
Thank you, Dr. Colombo. So now we have about 10 minutes left for our discussion. So if I might start with maybe asking Antonio a question. So a very, obviously very innovative way of treating very diffuse disease that, typically we might put super long stents in and the results are not very good. As you sort of collect more patients, would be a sort of a routine follow-up at 3 months or something like that, and see whether there's any sort of early restenosis and stent those area that were sort of missed the first time. Would that be something that you would also think about doing?
Yes, you don't necessarily need to do an invasive evaluation. Now with a CT scan, you can evaluate the patient after 6 months. This approach is not necessarily to prevent restenosis. Restenosis can occur after stenting, can occur after DCB, but it is an approach to make the treatment of coronary disease more physiologic in the long term. I don't like to see patients after 3 or 4 years with the LED all covered with metal stents anymore.
All right, thank you. Anyone on the panel want to ask questions to any of the speakers?
I have a question.
Yes.
First of all, I would like to thank for our presenter for very useful, for informative and excellent presentation, useful for the beginner. My question to Dr. Bong Kun Ku, as you show, the case anomalous RCA intra-arterial type, you take the invasive FFR to check that it have the patient symptom or not. My question is, what do you think about the advantage of the invasive testing compared to non-invasive as the exercise state test or the butamine state echo for this case?
So thanks for the very important question. So that this disease was previously a surgical disease because we didn't have a regular CT scan. So when the young patients anomalous RCA symptom, it was surgery. But now we see many asymptomatic patients, and we know that the limitation of non-invasive tests gets higher and more in congenital disease. So it's because that the coronary artery and myocardium is adapted so that you will not see any significant defect and significant changes. So that's the reason why I stress the importance of the invasive test. And we don't have much data yet, but the invasive test may be better than the non-invasive test in the special complex anomalies.
Thank you very much. Thank you.
So maybe a follow-up question to Bon Quan as well. It's like, when we choose the FFR value of 0.75, 0.8 is really correlate to ischemia and maybe some symptoms as well. But as I think Dong-Wook shows as well, it depends on what sort of the manifestation of the coronary disease is, symptomatic angina, sort of revascularization, and then obviously, plaque rupture, infarct related. I think that it shows the power of FFR, but it still also shows some weakness of the FFR, right? Because we could not use a value of 0.85 to predict, infarct occurrence, because that would be too many lesions and so forth. So I think that's the part of our limitation, and really how to pick up lesions that may give you trouble in the future, which obviously our surgeons do it a very simple way, just bypass it, right? Then, you don't have to worry about that anymore. So for us interventionalists, it's a little trickier to pick out lesions that, is not normal, but has some potential to cause you trouble in the future. So how do we evolve FFR any further? Is there anything that you can think about that can help us with that?
So I think that that's a very important question, because in terms of vulnerability, physiologic vulnerability means a little bit different from the per vessel ischemia. So previously, we used this index as a dichotomous decision for revascularization or not, but we now know that there are some vulnerable lesions. So I think there are many ways to use that, but one simple solution for that is using delta FFR across the lesion. So if FFR is 0.79, long diffuse disease, the risk of AMI will be low, but even FFR is 0.82, if that pressure gradient, like Antonio mentioned, the 10 millimeter mercury difference, so that if that pressure gradient acts only on a very focal LAD lesion, I think the risk of future events will get very higher. So that while working with the physiology, now I am focusing more on local physiologic disturbance or local stress rather than per vessel index.
Very important. So almost like we need to have a little bit of a mechanical pullback of FFR so that you can, be very standardized, so that you don't pull too fast or too slow. So you can evaluate the gradient of FFR to pick up local, hemodynamic disturbances that create, turbulence and so forth.
So my comment is, Alan, you point out the very essential and the unmet need point, and we are, as shown in my slide, we treat the functional ischemia, also anatomical ischemia, anatomically vascularization, functionally vascularization, okay, but we don't know is how can we define the future vulnerable plaque that was associated spontaneous MI. The occurrence in the bypass surgery is always good, MI reduction, and prevent the spontaneous MI. But the PCI, that was regarded as one of the major limitations. So, and nowadays, recently, a couple of weeks ago, we complete the prevent trial. We take a 6-year complete enrollment, 1,600 patients. There was a vulnerable plaque. Its physiology FFR is 0.8182, but plaque burden 70%, and we randomization, one arm is aggressive OMT versus one arm is mechanical treatment using the drug-eluting stent, and we are waiting that result, and 1.5 years later, ACC late-breaking trial, SJ will present that ongoing result, this prevent trial.
Great. I think that'll be very important to really combine physiology to pick up what, we're talking about turbulences and also the plaque volume, because I think we from both a lot of the vulnerable plaque trials, that plaque volume certainly predicts some of events, and also makes sense, right? A little bit more progression can give you also a lesion as well. Any comments and questions from anyone else?
I have a question for Dr. Nakamura.
Yes.
If the patient with critical left main disease, with triple vessel disease, and the airway function is mildly decreased, for example, like 40%, and when you're doing the left main bifurcation PCI, how do you decide if the patient needs support or not?
So I'm sorry?
If the patient has a critical left main disease with triple vessel disease, and the LV function is mildly decreased, like 40%. And when you're doing the left main PCI, how do you decide if the patient needs mechanical circulatory support or not? Or just do the PCI without support, or how to decide?
So actually it depends on the situation, but I think currently we have many data about impeller support. So if we can use, maybe I think better to use the impeller support, But even if not, maybe I think if you can do the quick procedure, maybe we can do it.
And sometimes a little bit measurement of hemodynamics may be helpful a little bit in terms of wedge pressure and things like that helps a little bit, because at EF of 40% could be really, low filling pressure, everything is fine, versus high filling pressures, and that might push you towards support.
Is there, Alan, I really have no idea. Is there any data about prophylactic mechanical support to be better, for any complex PCI? So it's just a simple question.
Yeah, I think the data is really, not that helpful. Obviously the various shock type of trials or obviously shows that it's helpful, but in a routine person coming in, for me as an outpatient to coming in, whatever the EF is, you probably don't need mechanical support to do your PCI, especially as Dr. Nakamura said, timing. The more you dilate vessels, keep them open, to keeping them closed, do multiple inflations and wait and this and that gives you more trouble. So I think the quickness, as you have shown, Dr. Park and Dr. Park as well, if you do left main, do it quickly. And I think, also Antonio as well, like quickness helps with dealing with lesions and not keep them occluded for, minutes and so forth. It's very important in preserving LV function during the procedure.
All right. In terms of, Dr. Dogubak presented some, issue about the PCI versus bypass surgery, right? I have some short look at this up to this point. So many data, including, main and Excel, currently the Excel study, freedom, syntax studies, many study. All right, meta-analysis clearly show that, some diabetic patient that's multi-vessel, the surgery is better. However, I think we have to define, in terms of in detail inside any studies, and in terms of functionally, anatomically, completeness, incompleteness, and so still, I have some controversial thought in terms of any triple vessel disease or main disease. Very strong issue is feasibility of PCI. Very, undefined, definitions. However, very good functionally, FFR, guided, anatomically feasible for stent, feasible for PCIs. We can do that. And we need the data. And so we also wait for some, Dr. the famous 3 study give us some insight and compare with the PCI versus, conventional surgery though. So still, I think it's concluded issues in terms of, PCI versus bypass surgery, even in multi-vessel, 3 vessels, including the main disease. So, what do you think? Any comment on this? And so I personally really want to do some future studies in functional concept involved in the function, anatomy, 3 vessel, including main anyway, and we have to adding the feasibility concept of PCI. So, go back.
So, as I fully agree, your comment is there was, I think, the same line with Dr. Antonio Colombo. We should distinguish malignancy versus benign, and we can treat all region with the PCI, and it's a well-defining, it's a suitable patient, eligible PCI candidate. It would be essential for in the contemporary PCI setting.
Yeah, I think PCI for treating, triple vessel disease, left main disease is. You on one side, if you overtreat, it's no good. Treat too much. On the other side, if you undertreat, left with ischemia, that's no good. So I think the feasibility of creating complete revascularization in the perfect spot, I think would do as well as surgery. It's just the other 2 sides that gets you in trouble compared to surgery. So I think that's really, each case is almost its own case. It's very difficult to lump them all together and compare, my thought. because anatomy is so variable and how to technically treat them in a perfect way. And if you can treat it perfectly, I don't see any reasons or worry about, comparing to surgery. One last thought, I think, surgery, we've given surgery too much credit of improving their technique. I think there's really not a whole lot of difference over last 20 years in terms of, using arteriographs, but they actually, the surgeons and the cardiologists following these patients have been treating with much better medical therapy. In the old days, the surgeons bypass and they just leave the LDL alone. They never, do anything, and no antiplatelet therapy. So, but now they pretty much all trials shows that they are, at least the people following the patients are aggressive on cholesterol lowering, aggressive on, various risk factors to a certain degree. So comparable to PCI medical therapy. So I would say that, surgery is doing better overall because of that than the technique itself, because the technique itself really hasn't changed that much. If you look at it, over the last 10 years, you can say better preservation, this and that, but I just don't believe that. And obviously minimally invasive has nothing to do with it. It's just, it's a cosmetic difference. The inside is still the same. So that's my thought. Sorry, anybody want to have some last questions? I think Dr. Kwan has a question.
Okay, I have one question for Dr. D.W. Park. So you nicely demonstrate the strategy about PCI versus CABG, but these days we also use the approach, hybrid approach, because we cannot say that SVG patency is much better than stenting. So how about your opinion for the hybrid approach, the strategy or the options, such like that?
Yeah, I know there is some ongoing trial, but it's not well done. Is I remember as Greg Stone also, and the John Fuskas was PI. There is doing some clinical trial, hybrid trial versus some other trial. But I think some feasibility is a hybrid trial, not suitable for real practice. It's just a simple procedure, and then it's a general anesthesia, open heart, something like that. Although they are using some minimal invasive bypass surgery, it's surgery, so still surgery. So I think it's a hybrid. I'm opinion some antagonist for hybrid surgery.
It's a complex thing, and then you have to deal with the antiplatelet therapy, this and that. So it's cumbersome a bit.
Definitely.
Dr. Park, you want to finish up and close?
Yep, it's okay, right.
Yeah.
No, you
okay.
Do that.
Yeah. Right. So I think we have four very important and stimulating lectures, and I think it's still this questions of complex PCI, bypass surgery versus PCI is still kind of out there. I think we have a lot of trials, but still I think for many of us, the individual patient is really what we're choosing for, and not trials, right? Because you're comparing, apples and oranges a bit. So it's hard to know. They're both fruits and they will still be probably healthy for you, but they're really very somewhat different. And each patient may fit an apple better, and some people will fit an orange better. So I would say that, we still focus on patient and individualize them. And also, the operator skills that's as Dr. Nakamura showed, timing is important. And if you have, complication, you need to know how to deal with it. And I think physiology and imaging are still on the forefront. We still have many parts to learn, as maybe, we can get even better fidelity of the pressure signal, that we can actually get a little bit more into the micro environment of the blood vessel of flow and pressure. So I think all that is very exciting, and still, is the beginning of, next phase of treatment of coronary disease. Thank you so much.